Hello and welcome to the Pediatric Dermatology Research Alliance Medical Student Research Cohort. This is our second session in our year-long program. So as we get started, I'd like to introduce Dr. Carrie Coughlin. She is the chair of PeDRA's Early Investigator Committee and oversees this program alongside the PeDRA Mentorship Program. Dr. Coughlin is a pediatric dermatologist and assistant professor at Children's National Hospital in Washington, D.C. So now I will turn it over to Dr. Coughlin to introduce tonight's guest.
Hi, everybody. I am really excited to introduce our speaker for this evening. Dr. Carrie Coughlin is an associate professor of medicine and pediatrics at Washington University School of Medicine in St. Louis, where I trained. And she is also the current treasurer of PeDRA and our former outcomes committee chair. She's done quite a bit of both quantitative and qualitative research in pediatric dermatology. And we are really excited that she's agreed to chat with us this evening a little bit more in depth about, our last session focused on refining our question and how do we get to the literature to figure out if this is a question worth answering and has been answered before. And now Carrie's going to kind of help us go through study design and outcome measures in a little bit more detail so that we can make sure that we are setting ourselves up for success to answer the question that we've now come up with. So without further ado, I will turn it over to Dr. Coughlin.
Well, thanks so much, Colleen. Thank you for inviting me, and thanks, Jen, for making sure everything runs for us tonight. So we will dive in here. In terms of conflicts, I don't have financial conflicts, but it is good to know if you're speaking to a homer for the organization, which I am, being treasurer for PeDRA right now. And then in terms of the types of grant support that I've had in the past, just thought it would be kind of helpful to see that, you can have a variety of things from a variety of groups. So early on in fellowship, I had a grant from the American Acne and Rosacea Society, and that was a prospective human study collecting microbiome specimens from pediatric patients with acne. And then I've had some grants from PeDRA, most notably one for secondary data analysis of pyogenic granulomas. And so that was working with our genomics and pathology service here at WashU to do some sequencing of these lesions, working with Path to actually get them and get the tissue out of the specimens, and then potential collaborations with other researchers across the country on that one, actually. And then a Derm Foundation Career Development Award that was for qualitative research to do interviews with families and patients who have congenital melanocytic nevi, and then developing a patient decision aid to support decisions about surgery and imaging screening, and one card that's just kind of an overview card for general educational purposes. And so a variety of types of grants, a variety of sizes of grants, and these are only funded when you do have a very kind of specific and interesting question, and that you demonstrate that you have really thought through the methods for the project so that you can prove that it is kind of feasible, achievable, and valuable. So that's what we're going to dive into here as you're thinking about kind of putting together projects. The question session that you had last is super important because that your primary research question will determine a lot of your methods. You want to have kind of one primary specific aim, and then you may have secondary aims. The reason I mentioned that terminology is that specific aim terminology is one that NIH uses, and for any grant, you have to submit an aims page. And so other organizations will sometimes take that language and ask for that as well. And it's really kind of what is the overarching goal of your project for that kind of main specific aim. And then you can have kind of sub goals beneath the aim and kind of multiple hypotheses, but all kind of driving towards one main point of your project. And then you're going to need to define your outcome measures. They're going to be part of your results and very important to the success of your project because you're going to kind of evaluate your project based on the outcome measures. So when we think about these specific aims, you're going to choose your methods to be able to answer the question that you're asking and either prove or disprove your hypotheses. And so that's where it kind of things need to really all tie back, and it needs to be very clean and very straightforward, such that you want somebody to be able to read your specific aim, potential sub-aims, and the methods and say, okay, I think that the methods that this person is laying out to answer this question makes sense and is going to actually answer the question. Because if you have a disconnect between your methods and your question, then you're not going to get funding, and you're also not going to actually be able to answer your question. And that's pretty brutal to go through a whole project and then realize that the things that you were doing were not actually in service of the question that you were trying to answer. I have here just a link to the specific aims instructions that's on one of the NIH pages, just in case that's helpful as you're putting together grants or thinking through projects. So then you really want to think about what type of study are you going to do to try to answer your question, and then you'll kind of have multiple methods for each kind of subtype of project. So we're going to walk through these different main buckets of projects: the quantitative, the qualitative, and then the mixed methods projects. So quantitative studies are what people are pretty used to thinking about and what are kind of taught from early on in medical school. Typically, there's going to be discrete data, numerical data that you're going to collect. You can analyze it using statistical testing. I know you all have reviewed the stats discussion with Amy Burrows-Stein. That was kind of that pre-information for this talk. But it's really thinking about things starting as simple as case series and then working your way up to a systematic review and meta-analysis. And so I've got here the kind of typical pyramid that we think of in terms of the data hierarchy for different types of studies, and in terms of interventional studies, really thinking about the randomized controlled trials as being the top of that. But when you think about any of these types of projects, you are typically going to be collecting discrete pieces of data and then saying that either a statistical test kind of proves some relationship, or you're going to be using descriptive statistics to talk about kind of counts and frequencies. Meanwhile, qualitative studies are going to be kind of answering some kind of next level questions, I would say, like answering why and how either something is done, something is experienced, or patients perceive something or act a certain way. And you're kind of looking into some of the kind of reasoning, beliefs, preferences behind decision making, behind behaviors, behind interactions, and experiences of something like a diagnosis. And so the types of things that you're going to be doing within qualitative studies are things like interviews. So that can be kind of a one-on-one situation, or one person talking to a couple. You can use focus groups where you have a primary interviewer, probably somebody taking notes, and then a group of people that you're talking with. You're going to get different types of results with those different strategies. So there's things that may be kind of more private, more individualized, that it makes sense to do using interviews, or there may be kind of generalities and kind of intergroup interactions that you're hoping to elicit by having multiple people there, that you might prefer using a focus group to get answers to some questions. And then there's other things like kind of photo voice, arts-based projects, many different ways to get at the why and the how behind someone's experience or decision making. With this type of research, it is important to think about who you are as a researcher, what you bring to the table, and what some of your inherent biases are going to be, that you may not, you don't have to think about that at all when you are collecting numbers and then analyzing the numbers, as long as you are staying true to the statistical tests that you set out and those methods. Like, it doesn't matter kind of who you are, what you bring to the table. But when you're analyzing something like an interview or a focus group information, you have to realize that your reading may be different than somebody else's reading of the interviews or the focus groups, based on where you come from. So it's just really important to notice that inherent bias, but also kind of your positionality and how that may be different from somebody else. Or, for example, when I was doing my qualitative work on congenital nevi, I did not interview participants who were patients in my clinic because I did not want to have any perception that their answers or participation would bias me in my care of the person, for example. And so there's other sorts of type of biases and interactions you have to think about with qualitative studies. Meanwhile, when I interviewed colleagues, like I interviewed them, and potentially a medical student might have, but then say that medical student were going to be applying for residency at one of the programs, then I don't know, they might perceive some potential conflict if talking to somebody in this sort of research setting. So there's kind of more variables that you have to think about a little bit differently for qualitative studies. I wanted to let you know that similar to, hey, there are rules about statistical tests, or hey, there are very defined ways to define a case, to define a control, or you're going to kind of propensity match people for your controls, et cetera. There are kind of guidelines for qualitative studies as well. And there are very detailed reporting guidelines recommended. This SRQR and this COREC 32 are two different sets of guidelines. And it's important to actually think about looking at these as you are designing your project, because you don't want to be retrofitting what you did to this reporting guideline and feel at all at any point like you need to fudge anything, because you always want to be kind of true to the research and true to the process. And so you want to have looked at these checklists ahead of time to think, oh, I need to make sure I hit all of these points when I'm designing my study, when I'm collecting the data, and then you can kind of report it true to form. And then you have mixed method studies where you're going to collect both quantitative and qualitative data. And kind of a piece to think about with this is you need to have a reason to collect both types of data. You don't want to have numbers just to have numbers. You don't want to do interviews just to say that you did interviews, but you're not going to have a large enough cohort to actually be able to make conclusions based on the information in the interviews. So more data isn't better data, but if there's a reason to maybe, you do a standard survey study and then you actually follow it up with interviews to get some background on some of the kind of questions or responses from that survey, like, hey, that might make sense. Or if you're doing something like a survey validation where you've developed a survey, you're going to kind of administer it to people, but then you have to do maybe some cognitive interviews for folks to make sure that they're answering the question that you're actually asking, and that they're like interpreting the question the way you mean it to be interpreted rather than a different way. Those sorts of things you might need to use mixed methods to get the information that you're looking for. You do need to be thoughtful about choosing your outcome measures, because this will partially define the success of your study, but also determine kind of where it sits in the literature and to which other studies it can be compared or cannot be compared. So there are many different standardized tools to measure outcomes. So and I say that very specifically because it may be that you're kind of tempted to create a survey to give to people at the end of some sort of intervention, and that's going to be your outcome measure. Like, are they satisfied with the intervention? Well, you can certainly do that, but that's not going to then help you be able to compare your project to another project, because you don't have standardized questions that you were asking or standardized measures. So thinking through that, here's an example about studying eczema, and kind of a key point for a trial looking at eczema could be looking at pruritus or itch before and after the treatment or intervention. So you could say, before the intervention, are you itchy? Yes or no. And then after the intervention, are you itchy? Yes or no. But you can't say much more other than that kind of binary yes, no. You could think about, hey, do you want to know the degree of itch? Do you want to know kind of how commonly they're itchy? Do you want to know how itch has changed over time? Do you want to know the impacts of itch on quality of life? So those are all asking about itch, but they're slightly different questions. And then I have some examples of validated questionnaires that all ask about itch and or quality of life generally related to dermatology, specifically with itch, or those kind of average itch or worst itch scores. So that data is going to be able to be compared to other studies that have used those particular surveys. And then you also want to think about, as you're collecting this data, like who's actually answering it. So when you're doing kind of adult studies, that's pretty straightforward. Most of the time it's the adult, unless it's a significantly older adult or somebody who has some cognitive impairment, in which case it may be a proxy. But in pediatric studies, a lot of times you will have a parent or guardian who's answering questions. That could be a proxy who is answering the forms. Are you actually asking it of the physicians involved in the care of the patients? Well, that's going to be a different answer potentially than the caregiver or the child might answer. And then when you're thinking about pediatrics as well, different surveys may have different ages. So like when we think about the Derm Quality of Life and Derm Life Quality Index, that is for adults and then down to kids of like age 16. Then there's the Child's Dermatology Life Quality Index. That is going to be 16 down to kind of like a preteen. And then there's a image version of the Child's Dermatology Life Quality Index that you'd use for even younger kid. And then there's the proxy questionnaires. So it's very important to think very specifically about who you're going to be asking these of, and then making sure that you have the correct questionnaire for the age group as well as the person answering the questions. I
Carrie,
think,
we did end up getting a couple questions in the chat back
yeah,
related to determining type of study. So the first question was, could you address any funding sources and publication platforms, either derm or otherwise, that are traditionally more qualitative research friendly?
sure. So I think that's a good question because we're always looking to try to apply to or submit to people that are going to be wanting to read our stuff. I'll say in terms of qualitative research journals, it depends a little bit. So there's a whole literature on like decision making, for example, that has its own set of journals separate from the clinical journals that we think about. So like, for example, for my Choose CMN project on decision making for children and families with congenital nevi, we could go through that literature that's based on shared decision making and kind of go to one of those journals. Or we think about going to a clinical journal, and part of that decision making is, well, who do you really want to read the paper, and how do you want to kind of disseminate the information that you've gathered? Like who's actually going to implement it the most, or learn from it the most and then apply it to something. I would say in the derm literature, I think about places like JAMA and BJD as being qual research friendly. I mean, PeDRA is definitely that way. But really, if you have strong methods and you have strong conclusions, really any of the derm journals is going to be happy to have your paper. Because if you have structured the study rigorously enough that, it doesn't matter if it's qualitative or quantitative, the conclusions are going to be pretty compelling. You can also think through like, say you're asking a question that's really kind of focused on either surgical outcome, surgical experience, that may go to a general derm journal, but you may be looking at something like derm surgery, again, just kind of similar to how you would think about placing a quantitative study in a journal that's going to have primarily the main audience that you're trying to reach. And then in terms of funding sources, oh, I don't think, in terms of when we think about funders like the Derm Foundation, American Skin Association, I mean, I think any of them tend to fund quantitative projects because that's what has been most submitted. And that's what people are trained more to do historically through medical school. So many people that are kind of my vintage never had any qualitative research training whatsoever. So that's not what they were doing because they haven't been trained to do it. So if you have some qualitative research training, you can really apply to any of the kind of typical funding routes. You just do hope that they have somebody that understands the kind of the methods and the language that you speak when you put in a qualitative project. I think and if you're thinking about like a large funding organization, something like PCORI, so the Patient Centered Outcomes Research Institute, would be definitely interested in qualitative work. But I think there are other considerations with funding organizations other than the type of work. So like PeDRA has had PCORI funding. I have, heard from other folks that, it's a great option. And for other folks, it's like, oh, it's really rigorous. It's hard to get anything through there. So for that, truthfully, I think if you have a well-designed study, you can really submit anywhere, because people are more and more recognizing the need for the learning of the why and the how to inform what we're doing, and actually to inform kind of success and uptake of interventions. So it's not a specific answer, but truthfully, I think it ties back to this presentation, which is like, be really solid in your methods, really know your literature and your language, and you can have success at multiple different outlets.
Awesome. Next question was, I may have missed it, but what types of reasons would be good reasons for having a more mixed methods approach, like qualitative plus quantitative in a study, or an example in which this makes the most sense?
Sure. So let me think through another example. Like, say this is top of mind because it was in a journal we just read, but say you're looking at TNF alpha inhibitor induced psoriasiform dermatitis in pediatric patients. And you're really interested in that because you think kind of scientifically it's pretty interesting. Well, are you like it really kind of boils down to what are your questions about that. So if you want to look at the triggers for it, okay, we can do that. It's been done. It can be done again, but it's really been done. But if you're thinking about, hey, what else can I bring to the table? It might be like, well, what was the patient experience of trying to treat through their psoriasiform dermatitis? Or what was the patient experience of being told that even though their guts was under great control with their infliximab, that to be able to have any sense of control over their skin, they're going to need to change their medication. So like, if you're asking kind of a complementary question after you've kind of discovered like, hey, who's my target population, then that could be a reason to do a mixed methods study. But if you're just looking at like, hey, how common is this? What do people do when it's been diagnosed? What are they treated with? I mean, then there's really no need for the qualitative arm. But if you want to kind of really, again, dig into the patient experience, and or think through like, maybe you do a study and you say, what is the treatment longevity of a certain drug? And you notice that of this basket of 5 medicines you're looking at, that 2 of them people switch off of like really quickly, and the 3 others people stay on for a long time. Well, you may be able to see in the chart review like why people are changing off those 2 drugs, but it may not tell the whole story. So maybe then you're like, hey, we've actually determined we're going to need to do a qualitative arm to try to talk with some of these folks that had to change off of drug to understand why they actually made that change, so that then you can determine, hey, does that justify actually one of the other agents being a first line agent? Or are there things that could have been done differently to help improve the kind of treatment longevity of one of those 2 first drugs? Hopefully that answers that question well enough. If not, type a little bit more in and I can try again.
I think that was good. Um, is there a good rule of thumb, and you may get to this, is there a good rule of thumb as to how many outcome measures are recommended per study?
No, you want to have enough to answer your question, but not so much that you are just surveying people, out of their minds, or that you are spending way more time than you need to looking for obscure data in the chart as you're kind of trying to find some answers to these outcome measures. I think basically kind of a guiding principle is you want to do the most with the least. So kind of get the most data that you can with the least burden on your participants and on your researchers. And you don't, again, it's the more is not necessarily better. So you don't want to collect things just because you can, because that's going to take time. And then at some point, you end up, if you start doing a ton of statistical tests, you're going to have to then do your statistical test to correct for the number of statistical tests that you're doing, right? So that's something like a Bonferroni correction because you've asked so many questions. So I think what you want to do is think, okay, what is, if it's for that kind of eczema and itch example, like what do you, when you're looking at, say, whether it be a drug or a behavioral intervention, what is actually the most relevant to patients? And so maybe we'll get into this in a little bit, but maybe that's where it's talking with some patient partners ahead of time to say, hey, what's actually most important to you guys when you are making a decision about starting a medication or thinking about a behavioral intervention. And then you have outcome measures that are going to provide data that speaks to those things that are most important to families.
Thank you. And then the last one, which may be pretty quick, is what softwares do you prefer for coding qualitative data?
Oh, this is a more loaded question than you know right now.
I've asked you this question.
Yeah, so I had the most experience with NVivo, so that's NVIVO. I liked the platform. It and it is a kind of either purchase a student license for a couple of years or purchase a permanent license kind of indefinitely for the version of the product that you have. It was actually decent in terms of comparing data initially, and then also kind of doing the actual coding and then running reports. So I liked that. However, in a recent project, I have been working with a resident and another trainee, and the NVivo comparison function like just didn't work. And it wasn't because they were using like different versions of the software. There was just something with it that it was not working. And if you can't easily compare coded data, then it's really problematic, because typically when you're doing qualitative research, you're going to have kind of two coders, at least initially, and then compare the coding such that then you come to consensus, and then you kind of by kind of repeating this comparison over time, you get coders to converge on how they understand the codes and how they're applying the codes, such that then potentially they can kind of code independently. But if you can't easily compare early on, it's really painful. So another option that I've worked with is Deduce, Dedoose. That is basically a pay by the month sort of product, which is nice because the initial like buy-in is really low, but then you just really have to think about like you want to be efficient with using that so that you use it for the months that you need to use it, and then you're done, and that you're not kind of continuing to have to, if you're checking in once a month for 12 months, you've paid for a year's worth of it when you really probably only needed like 4 months of it to be able to actually use it. And that one is kind of an online thing. There's no kind of install to the computer, pretty kind of low barrier, easy to adopt. That's what this other project kind of switched to. And I will tell you, the resident and trainee are much happier using that because it has been very intuitive for them. There's multiple other platforms that I do not have experience with, but those are the two that I have used and my experiences with them.
I'll also say I've used Atlas T for mine. Ask around and see if your institution has a license for something already, because if they already are paying for something that you can get for free, then that might be your best bet too.
Yeah, and
Um,
it's interesting at WashU, we had certain departments that had licenses for some products, and then other departments that didn't have the license. So you could use it if you were in the department, but if you were outside of the department, even if you were collaborating with the department, you could use it for free. So good to learn the rules from your mentor too.
those are all the questions we have right now.
Okay, great. All right, we will venture forward. I think we've kind of reviewed this as we're choosing outcome measures. Some other things to consider. Number one, do you have a mentor or mentors to support you through the project? So you've come up with a question, and people come to this differently. Some people are working with their mentor and coming up with a question. Other people are kind of thinking and developing a question independently and then interested in moving forward with a project. But it is really important to have a mentor to support you during a project. And it's just, as I have in this note at the bottom, you don't know what you don't know. And you can save yourself a lot of trial and error and regret by having somebody to help you as you're walking through a project. And that doesn't mean they're just going to tell you what to do from the beginning, but that they will help you troubleshoot. And as you're kind of developing things like deciding what your outcome measures are going to be, and even in defining the scope of your project, your mentor can be invaluable in terms of saying, this is totally reasonable there, or hey, there's no way this is going to be feasible to do for X, Y, or Z reason. How can we reshape this project to become feasible? And then thinking about, again, how big is the project going to be? Do you need other people to help you with data collection, analysis, with writing this up? Especially, for example, for a qualitative project, like I was mentioning, most of the time you're going to want to do dual coding, at least in the beginning parts of the project. So who's going to be that other person coding? Is it going to be your mentor? I can tell you from the mentor side of things, yes, I'm certainly able, but my time availability is going to vary across the year and across different years. So it is probably helpful to have somebody who is a peer or at another level that can also be trained, that can be helping with that coding. And then you work with your mentor when there are discrepancies in coding, or in terms of like the training, the learning how to do it, and then also the analysis. But you really want to think about that ahead of time, because what you don't want to do is get to, hey, you've got all this data from all these interviews that you did, and then all of a sudden you're like, shoot, I have no way to get through all of this on my own. And then you have to kind of pause to get somebody else on board, bring them up to speed. Whereas if you thought about it at the beginning, you'd have somebody kind of ready to roll once you have the data. And then thinking about patient-centered research, how are you involving patients in your project? It is certainly helpful to think about this from the very beginning of putting together your question. And then, like I said, potentially talking with patients or patient advocates can help you decide which outcome measures make sense to use, and also sometimes where you present your data. Like, is there actually like a patient advocacy meeting where it would be important to present this data? Like, great, that's another opportunity for you, but also a way to connect with the people who are kind of the end users of what you're thinking about for your data. And then you can also talk with your mentor to think about, hey, if there's not like an organized patient group that would make sense to partner with, does your mentor actually have a patient or have a colleague who has a patient or a parent or an advocate who could provide input? Like, hey, could they vet your survey materials? Can you say, hey, we're going to look at eczema and we want to think about itch and sleep, and they could provide input. Like, actually the most relevant thing to us right now is, does my kid make it through the day at school, or do they have to go to the nurse to get something put on during the day? Like, maybe you wouldn't have thought of that if you hadn't talked to somebody who was a patient or a patient advocate. And it's, kind of really thinking about following the guidance of having patient-centered research not just be about patients, but with patients. And then you really want to consider how much time you have to complete your study. A rule of thumb for this is it will always take longer than you think it will, every single time. Oftentimes you're going to have to double the timeline that you think is going to be reasonable. So you want to plan ahead, and you want to think about, do you have any really final deadlines that you need to adhere to? So for example, like when you're graduating medical school, do you want your work to be done? I will tell you your answer is yes. I will tell you from personal experience, when it's not, it's tough. I've worked with multiple people where their projects are still ongoing when they're in intern year, and you think intern year is going to be like, third or fourth year, and then you realize, oh my gosh, this is a different ball game. So it's really important to plan ahead and try to really kind of stick to some deadlines that are going to be important for actually getting the study completed and written up, so that it's not something where you spent all this time working on it and then you never get the paper done. So when we think through the process here, you have your idea, you develop a study plan, which is this, okay, what methods am I going to use, which outcome measures are we going to use? go through the IRB if you need to, got to collect your data, you got to analyze it, write up an abstract or two, write up your paper, and then get to publication. Now that timeline can be longer if you need funding. If you need funding and you don't have funding, you're going to have to do some grant applications. Okay, well, that's going to take some more time. And then sometimes you're going to move forward with submitting the IRB, but you can't actually do the work if you don't have the money to pay for it. So just really the planning with your mentor is important. And that's another kind of piece where you might think, hey, you have this idea, you've gone through everything. You're like, I don't think this will require any money. I don't need any funding for this. And then you talk with your mentor who's like, hey, I've done projects like this before. And if we didn't give people gift cards, they didn't want to participate. And then when we added gift cards, our participation rate skyrocketed. Like, okay, well, maybe we need to do gift cards. And then you got to think about where that money is going to come from. And then some kind of general things to be thinking about, like, will your project actually produce useful data? And by that, I mean, can findings from what you're doing actually be implemented? Are the results meaningful either to providers or patients or drug companies? Like, is there a population to whom these results are meaningful? And I'll give an example here of this example of timing and pre-post studies. So say you're doing an educational intervention and you're going to survey people before the educational intervention, and you're going to survey them after the educational intervention. You're going to say, hey, look, there was this bump in knowledge, which hopefully is a proxy for them carrying that forward and then potentially changing behavior. Well, number one, you're not actually assessing the change in behavior, so you can't actually comment on that. You're just looking at knowledge. And if it's an immediate recall sort of thing, that gives you no sense of if they're actually going to retain the information and or be able to apply it in the future. So to make your results more meaningful, you might think about having a delayed time point. So you may do an immediate pre-post, but maybe you have a 6-8 weeks later where you do another questionnaire with folks. Now, yes, participant retention, getting those things back is challenging. I 100% know because I've done it. But that might give you more meaningful data if you say, hey, two months after the fact, people still actually had a higher knowledge base. And or then you can actually ask some questions about behavior where you can see that, hey, the information that we talked about, are people actually implementing some changes based on that? All of a sudden, then your study actually becomes much more meaningful, because then not only do you show an intent to change potentially based on a questionnaire, but you can actually show if there has been change. And then you think about too, will the results of the project actually change behavior or opinion? And I put in here thinking about public health experts, lawmakers. I mean, there's so many different target audiences for the research that we do. And you can think kind of creatively about the types of projects that you're developing, to think about if you're trying to target a particular group like lawmakers to change something. And then I do think it's always good to remember that just because you can do something doesn't mean you should do something. You really want to think about producing really meaningful, useful information from your projects, because just to get another publication isn't a great reason. You want it to actually change science, add to science, change maybe something that could be an outcome for patients to improve care, or make a difference either in a patient life, a provider life, or potentially something in the public health arena. And you really want to think about centering it on children and families if you're going to do pediatric dermatology research, because clearly they're really our primary end user when we're thinking about our research. So I have had a Derm Foundation grant. They are how I learned a lot about the qualitative stuff and got a lot of experience with my qualitative research. And I am happy to answer any other questions people may have.
Perfect. Thank you so much, Carrie.
Sure.
I feel like a lot of these things are like, yeah, okay, cool. Like I'm writing this down, I'm thinking about it, and then when you actually get to making a study and you make these same mistakes like over and over again, it's like, yeah, I really wish I had like sat down and thought about this a little bit more seriously. So, thank you for walking us through that.
Thank you. No, and to speak to your point, Colleen, I think that's where sometimes actually the grant writing process, challenging as it can be, is actually super helpful, because it really makes you think through your question and your measures and your methods and your timeline in a really detailed manner that you might not do if you aren't actually applying to external funding and having more sets of eyes look at your project. So I do think, like, kind of, if you think about it from that angle, if each time you're putting together a project, you think about, well, what are the questions that people are going to ask me, or, you know, what are the potential kind of curveballs that people might say in a review, like, hey, why didn't you use this measure? Well, you should be able to defend why you used something and also why you didn't use something else. And so really taking the time to think that through at the beginning also helps make your paper writing a lot easier, because then you've kind of thought through the kind of questions and critiques that your editors and or peers are going to ask you in that paper writing process, so that then you've just kind of, it just flows a lot more easily when you can really defend the choices that you made.
We have a question. Something that I have been struggling with is the logistics around gathering survey data from children or families. Do you typically have patients and families complete surveys in the clinic or send them afterwards virtually? Also, do you typically have children complete the survey or their parents?
Great. So thinking this through, in terms of completing in clinic or outside of clinic, part of it depends on how much time are your surveys going to take. So if they are going to be relatively quick, trying to capture people kind of at point of service, if you will, makes a lot of sense. So for example, I worked on a project that was looking at kind of impacts of cost on decision making for patients undergoing radiological studies. So how did we capture those folks? We actually approached them in the radiology waiting room. And so thinking about, where is somebody going to be where they have downtime? So we catch them while they've already checked in for their study and are waiting to get called back. And then, hey, we can make use of that time, get the data that we need, and then the family doesn't feel like it's been a burden on them because they were sitting there anyway. Okay, awesome. That worked out great. Now, do we have to have somebody that's dedicated to being in the radiology waiting room to be able to collect those surveys? Yes, we do. But thinking about, those were all on iPads. So it was a, hey, do it while you're here. It wasn't like, here's a paper survey, we're going to give this to you, finish up as much as you can, and then mail it back to us, because you're going to lose a lot right there. So thinking about ways to make it easier for people to complete the surveys is also good. If your project is kind of, say you're doing some qualitative work where you're going to be interviewing folks, most likely then the surveys are going to be completed around the time of the interview. So whether that be virtually or in person, it makes sense to do it at that time. Because if you're even at the end of the interview, if you say, hey, I'm going to send you a link, please then complete these, you will lose people because they will not do them. What you want to do is, hey, here's the link. Let me know when you're done. You know, so you're sitting there with them, waiting for them to do it. And then if there are ones that you want people to start in clinic, but it is going to take a while, you can do that, but you want to think forward, like, okay, if they're going to mail something back, you need to give them a postage page pre-addressed envelope to be able to put it in and mail it. USPS, I don't know if this is a political statement, I don't mean it to be, but like, mail is not always reliable, right? So you're going to have a much better return if it is a say like a red cap survey that they're filling out. And then when they're done, they don't have to mail it anywhere. You already just have the data as soon as they're done. So you think through, like, hey, can you email them a link, or can you have them actually do it while they're in clinic with this link? And then maybe you, I don't know, give them a snack, give them the $5, the $10, whatever, to encourage that participation, to make doing it a little bit less burdensome. And then if you're thinking about children versus parents, it depends the questions you're asking, and it depends the age of the kids. So there are validated surveys for different ages of kids for different types of questions. So if it's an eczema one, there's like infant surveys that are done, but those are done by the proxies. But then there are like the itchy, so the CDLQI that you can have, like a 6-year-old can do that with the image one. So great, you can get the data direct from them. Then your question also becomes, do you collect child and proxy data and then compare those? Well, you ask yourself if that's going to be meaningful, because so that's not, that kind of goes to that question of, well, how many outcome measures do you have? Like, is there a reason to get a proxy report and a patient report? okay, you justify that, then it makes sense to do it. If not, pick whichever population you want and just have one of them do it. Because again, less burden on the participants if you're just going to do one, or if it's more meaningful, then you do two. And then you always have to think, if you're going to be asking the kids, are you asking them questions they can actually answer? Or are they just going to be asking their parents? So for some things, like if you're asking questions like, at what age did you start having eczema? Well, the kid probably doesn't know the answer to that question. So they're going to ask their parent. Well, so then do you just put that in a parent questionnaire rather than the kid questionnaire? Well, maybe that makes sense.
How do you ensure your qualitative study is impactful when it doesn't include quantitative data and while also accounting for bias?
This goes back to what is your question? So you want the question and the goal of the project to be meaningful. And then as long as you are kind of rigorous in your design of the types of interviews that you're doing, so there are interviews where you're just kind of question, answer, question, answer, question, answer. There's interviews that the type I tend to do, which are semi-structured, which is there's a core set of questions that every participant is asked, but then they can kind of go free form and then you find out new information. And then there's other types of interviews where people, it's almost like all free form and you just kind of get what you get. But so you want to think about, are there particular things that you want to be able to talk about after the interviews? Then you need to make sure that you're asking questions that will get you answers based on that. And if you want to know if your study, if like the question that you're asking is going to be impactful, well, then you think about, again, who is your target audience? And so like for my study on congenital melanocytic nevi, I mean, we involve patient partners from the very beginning. We're doing another study looking at outcomes of kind of decision making and treatments and experiences of treating vascular lesions, particularly port wine birthmarks and hemangiomas with laser. Like we involved patient partners from the beginning to know like what's important to you, what are some of your experiences to help guide how we were developing the interview guide and making sure that we're kind of getting information that is relevant to them. And then sometimes it's also talking with your peers and seeing like, hey, what do other providers find meaningful? What are questions that they have? And that's where groups like PeDRA are great, because you're talking in a work group and they're asking a bunch of questions. You're like, oh, I actually didn't even think of that because my institution always will do a feed and swaddle MRI for children under 3 months. And then you talk to somebody else where they're like, oh, my institution will never do that. We always have to do an IV and they always have to be sedated. And then you're like, oh, I'm going to think about different questions. And I like my questions about sedation and that experience, I have to think about differently. And the answer to my study can be more meaningful because I have incorporated the viewpoint from different institutions that like, hey, the way we do it is not the way everybody does it. So I think it's taking into account patient experiences, provider experiences, and really making sure that somebody else wants to know the answer to the question that you're ultimately trying to answer. And then you think about, how do I just disseminate the data, right? So you can do all the studies in the world, but if you don't get your data out into the real world, then it's not going to be impactful.
I have one last question. If you can, not to put you on the spot, but can you think of an example of a successful study that you've done where you were like, yes, like we did this thing really well ahead of time and this could have been a disaster, but we avoided it? And or an example of a not so successful study that either wasn't able to be completed or took a lot longer because of something, that was not thought of ahead of time during this stage of the process.
Yeah, I can give some examples with that. Thinking about, and these are, it's thinking about patient recruitment. So you can have the most interesting question in the world, but if you're going to be asking patients, you need to be actually asking the patients. And if you are not able to recruit, it's going to be, you're not going to be able to answer your question. So fortunately for like this patient decision aid project, we had a great cohort of people, pretty easily recruitable, validated stuff, that it worked out well. We did a next study looking at patient and parent experiences of surgery for CMN. And while the data that we got was super rich, We were trying to recruit more participants because that was a smaller pool than an all-comers, and anybody with congenital nevi pool is bigger than I had surgery on my nevus pool. So you've shrunk that patient population. Then we were trying to recruit through a patient advocacy organization, and they put information on their public facing Facebook page, and we actually got scam participants. So people that kind of mine some of these groups on the public facing pages for calls for research participants, and our interviewers, this it wasn't like very obvious initially, but then as they were getting to the end of one interview, we're like, oh, this isn't like a person who's actually had this experience. They are faking their way through this for this gift card that we're going to give them at the end. And we had multiple other people that were were scam folks, in which you can't tell when you're scheduling them, and then they could tell when they were actually interviewing. So that was a big lesson learned, that if something is going to be put on a public page for public recruitment online, like that's not a good way to recruit people. It needs to be on private pages, so people that are group members, because that's who you're trying to recruit. And so we shut down recruitment for that, because we couldn't keep paying gift cards to people that were not actually participants, and we didn't even know that was a thing. Like, who knew fake study participation was a racket? Well, it is. So that was a lesson.
Just gonna make a note of that for a study I'm designing right now.
Yeah.
Good to know.
Good to know.
We have another question. How do you, on the subject of gift cards,
Yeah.
how do you provide gift cards or other financial compensation ethically? I've found it difficult to recruit patients when there are multiple surveys or it requires them coming in for extra visits without compensation, which is totally valid.
Yeah, so I think this is an important question when we're thinking about stuff. Some of it depends on how burdensome is the study. So if you're actually requiring somebody to come in for a visit, like you're typically going to need to, like, that's separate from a clinical encounter. They weren't just kind of happenstance recruited. Like, you're going to need to compensate them. They're going to need parking. They're probably going to need compensation for time. And then if you want to get people to send back surveys or do surveys at multiple time points, yeah, you're going to need to compensate them. Otherwise, they're not going to do it. And I don't think that's being unethical. It's saying, like, hey, your contribution here is super important. We recognize it. We also recognize that participating in this study is a burden because it is your time. And so we want to thank you. So I think one of the ways that I try to think about it is, like, what is the scale of the compensation? So, like, and also, what are the risks of study participation? So if you have high risk, you're probably going to compensate more, but you don't want your compensation to almost be coercive, such that people are like, well, I really need the money, so I'm going to do it, even though I'm a little bit nervous about the risks of this. If it's a survey study and you're given a $5 or a $10 gift card to participate as a thank you, like, that's not coercion. That's just saying, hey, we actually value your participation, and thank you. And you could imagine, like, you get emails for surveys all the time. There's like, hey, you'll, even through PeDRA, you'll get interviewed. You'll, as a active member, you'll get requests for studies, and then sometimes it'll be like, hey, there'll be a drawing for a $100 Amazon gift card if you participate, and then you're put into the pool of however many participants there were. And that's acknowledging time and not being coercive. Now, if you're standing in clinic and you're, like, passing out toys to people who participate, and then other people can see who participated and who didn't based on the toys, like, that's not good, because then you're introducing some other ways of shaming, or the kid's like, I really want that thing, and then the parents like, oh, I guess we have to do it because we have to have that toy now, like. So you really need to think about how it's presented, and how people can kind of privately assent or decline, right? And then also thinking about the degree of the compensation.
Awesome. Thank you so much for walking us through this, Dr. Coughlin. Thank you so much for answering everybody's questions, including mine. I'm going to turn it over to Jen to wrap it up.
Thank you so much to Dr. Coughlin for her excellent presentation, and to Dr. Colleen Cotton for hosting tonight's event. For more information about PeDRA and our research tools, you can visit us at pedraresearch.org or follow us on social media at PeDRA Research. Thanks so much for watching.